What I want to do is just stay at a high level and talk about what is happening in healthcare in general. I have no disclosures related to this presentation, but give you sort of an overview. And I want you to think about how cardiologists sort of fit into the new paradigm of healthcare because it's a rapidly changing environment. I'm starting out with a slide made by accountants, not by a slide made by doctors. And why am I doing this? Because there is a major coalescence occurring really throughout the US, and I wouldn't be surprised if this is an international system as well, because what happens is when standalone academic medical centers, or standalone medical centers, start to coalesce into health systems, they create economies of scale. They have increased negotiating power. Sometimes that can be a negative if you read the New York Times about the Sutter Health System in the last day or two. But the other thing about this is that you see that if you look at bond ratings, which is sort of a sign from objective external observers of the financial health of the healthcare delivery system, what you see from this slide is that health systems, as of about 5 years ago, became much more economically viable than the standalone medical centers. So what does that mean for us? We have to start to think about not just how we perform clinical medicine, but how it intersects with the economic drivers of healthcare in this new era. Think about what real costs are, because we always think about costs perhaps in a somewhat fantasy way, but we'll talk about that in a second. The real drivers would be, frankly, personnel and supplies. So personnel or FTEs or full-time equivalents, physicians, nurses, advanced practice providers, or any type of physician extender, the support staff. These are your most expensive resource. How many people does it take to run this? And think, what about, besides the people, what are the expensive resources that we have to provide? Hospital care is very expensive to provide, especially critical care. And so the more we can provide ambulatory services, the less expense there will be on the health system. Emergency department care, incredibly expensive and inefficient, not because there's anything wrong with emergency departments, but because of the whole process of people not getting appropriate preventive care and using emergency departments instead of primary care or preventive care. Post-acute care, the skilled nursing facility, the long-term acute care hospital, home care, very expensive for our patients. The supplies, the drugs are extraordinarily expensive and getting worse. And the remainder of the supply chain, and of course the capital costs of an aging infrastructure that most health systems suffer from. The caveats that we have to focus on these true drivers. I get a lot of, I talked about the fantasies before. Here are the fantasies that don't really work when you're trying to think about or argue how something that you're trying to promote, such as, for example, a new approach to managing patients in your health system with coronary artery disease or end-stage heart failure. The cost of an OR hour, a recovery room minute, or an ICU day, or the cost of an MRI or an ICU day, these are fictional things because we just take a budget for a hospital and divide it into the budget for that particular area and divide it by, let's say, the number of hours per day, week, or year, and you come up with this arbitrary number. It doesn't really drive the cost. It's the other things we talked about that really drive the cost. If I get somebody out of the cath lab 2 minutes faster and I get them out of the recovery area of the post-cath lab 2 minutes faster, unless I need fewer FTEs, unless I need fewer supplies, I haven't saved a dime. So it isn't about utilization of resources at that particular level. It's about the actual individuals and supplies. And true then, the cost of the nurses, the anesthesiologists, the surgeons, the cardiologists, the support staff, and purchasing, maintaining, and staffing an MRI would be the opposite. So think now less about perhaps what we would talk about in the past, which was, oh, this is about quality, and it becomes more about value. And we're going to get to a slide in a moment that I want you to remember more than anything else. But what is value? Value is observed to expected mortality and complication rates better than benchmarks. Quality is going beyond the external measures, looking internally. What are your infectious complications, your length of stay, your readmission rates, and controlling costs? What can we do to reduce those ICU and hospital lengths of stay, the use of other expensive resources, such as blood transfusion, laboratory, radiology, consultations, and post-acute care. So the shift is starting to occur. In the past, in a fee-for-service model, we were fine. Providers were fine, the cardiologist, the endocrinologist, the surgeon, because they just would do more work and charge more money and they would get paid. But now, as we're starting to get new contracts, what happens is both the facility, the hospital or the ambulatory center, and the provider are starting to take financial risk because that's the deal that's being offered by the payers. And this isn't just Medicare and Medicaid in the US, this is Aetna, United, everyone else. So think about that shift. We're nowhere, certainly on the East Coast, getting towards something of a capitation where we would have a per member per month fee. It just doesn't really work that way so much on the East Coast, but the West Coast is perhaps farther along on that journey, but I'm not trying to spend too much time on that. This is the slide to remember. The slide is value is quality or safety or satisfaction divided by cost. That's really where we have to start thinking about things. So now that you know those true drivers of cost, think about value. And this is happening in the US. There's been a major shift, and looking at Medicare alone, the transition is such that now already, as of last year, something close to 90% of our payments are linked in some way to some kind of value. We have penalties for readmission. This is what this slide shows. We have penalties for hospital-acquired conditions like infections or pressure ulcers, and we have a value-based purchasing program that takes into account multiple factors related to the value of that care that we provide. And as I said, this isn't just Medicare. Medicare is maybe up to 6% at risk. Look at Aetna, Cigna, Emblem, Empire, Health First, which is a managed Medicaid that we sort of partially own as Mount Sinai Health System. So we do get per member per month dollars, but they're scaled based upon our star ratings by our own managed Medicaid entity, and United Healthcare as well. So think also about certain things. I'm showing orthopedics only for one reason. In orthopedics, only about 2/3 of the expenses related to the hospital episode, 1/3 is related to the post-acute phase, what happens after they leave the procedural side. And generally in cardiovascular services, this happens to be CABG and this happens to be cardiac valve, but it applies also to items like PCI, probably as well to procedures like TAVR. About 90% of the cost is in the main encounter, the procedural encounter. So as cardiologists, you should be thinking about what you can do to affect this in a positive way. And, of course, thinking about stratifying. Some people say that we spend about maybe 80% of our healthcare dollars on about 20% of the population, or, people have even, come up with numbers about, 50% on 5%. But whatever that number is, we know there's a high-risk pyramid, and we know that we need to devote extra attention to that. And so why do I show a slide to cardiologists about palliative care enhancement? Well, you take care of end-stage heart failure. You take care of patients near the end of life. And so thinking in a population health context, it's important to try to shift. Just notice at the bottom here, we made a major effort to make sure that our palliative care unit was actually filled with palliative care patients. And a large proportion of those patients are people at end of life due to cardiovascular disease. And thinking in a population health way is important for cardiologists as well as it is for an oncologist, as well as it is for other specialties. And so thinking about that, what do we do as cardiologists if we delay, let's say, the placement of a tracheostomy because we say, oh, they can wait a few more days? We create excess days. And when we work together with, let's say, intensivists and with a quality structure of a hospital to reduce the number of days until, let's say, tracheostomy and transfer to a long-term acute care hospital, we become part of an effort that creates a better value equation. So I'm almost done here. I just want to point out that even simple, silly things that we did where we just gave people an app which they took home, which was linked to a scale and a blood pressure cuff, and just having our pilot team call patients post-discharge, typically we took what was about a 25% readmission rate for advanced heart failure, and in this pilot it reduced it to about 11%. It's just a selection bias thing perhaps, but the point is we have to think more broadly. We have to start thinking less about episodes of care and more about longitudinal care for our patients. So in conclusion, We have a really different world out there. Are you going to, as the title says, going to be fine in private practice? Perhaps. But already, more than 50% of physicians in the US are employed by health systems or by large physician groups. And becoming part of that body politic, the value-based equation, is extremely important. Whether or not you're able to make your salary in a private mode, or whether you're working in a health system where you're perhaps paid based upon a productivity and a quality set of metrics, that's something you'll have to figure out as individuals. But the fact is, think about what's important. What's important is about the complex medicine, surgery, procedural medicine, especially, and the associated ICU care are at the epicenter of our overspending. We have to win at bundled-based models. We have to control the laboratory, the imaging, the unnecessary consultations. Did you really need that endocrinologist to tell you how to prescribe insulin? I don't think so. What about positively affecting outcomes? Would we be able to defer what's PCSK9 inhibitor versus standard statin therapy? And working together to look on performance improvement projects focused on the negative outcomes of clinical and financial concern. So what drives up costs? And you're in there. Respiratory failure, working to prevent these issues of avoidable harm, including infections, focusing on helping hospitals develop rapid response teams that can prevent the problem of failure to rescue. And moving palliative care upstream, it's part of what we all have to do. So thinking about this, I think, puts you in a proper position to consider what your role is in the future as you think about what is complex healthcare in a complex, evolving world. Everything's a moving target, and I hope that you find this talk a little bit helpful as you consider what your role should be and that of your partners and that of your trainees in the future world of healthcare as it evolves, especially in the US. Thank you for your attention.